Another ICH alumni, now a consultant at Apollo Children's Hospital, who's one of the best hematologists in the state. With more than 25 years of expertise in the field, she has done a lot of bone marrow transplantations in the state of Tamil Nadu. We take a great pleasure in welcoming Dr. Revati Raj.
Good morning to all my teachers and the new students that are here. It's always a great pleasure to be here every year, year after year. It's the same talk, but seeing new faces inspires us to do new ways of teaching. And I have all my favorite people in the first row. So thank you, Dr. Srinivas, for this opportunity. Bleeding disorders is one set of diseases which all of us are very scared about, because to see a child bleeding is quite a scary thing. And every year I have a new theme. Last year was Star Wars, and this year it's all Avengers. So you have to have a theme to do any talk. And just want to say that this is one condition which doesn't affect just the child, but has an impact on the entire family. So all of us need to know about it. And over history, people have realized that bleeding disorders run in families. So these have an impact just on the child, but also we know it's genetic. So we have to always have a look at the whole family to make sure another child with the same bleeding problem is not born in the same family. So even 1700s, there was a Hebrew law that said if one child had bleeding after circumcision, don't circumcise the next child, because they knew such conditions can run within families. So you know what happens when a blood vessel gets cut. There's vasoconstriction, there's a platelet plug formation, and a blood clot formation. So if any of these three steps go wrong, there can be a child with a bleeding problem. So you have to ask for the history very carefully. I just want to focus a little bit on platelet plug formation, because if you understand this cartoon, then you'll be able to understand platelets better. Red cells and platelets are the only two cells in our body that don't have nuclei. So they have to have glucose from the plasma, and that's why you are able to transfuse red cells and platelets without HLA typing. All the other cells of our body, if you take from one person to another, you need HLA compatibility, but only for platelets and red cells, since they don't have nuclei, you're able to transfuse, and that's the basis of transfusion medicine. But they do a lot of things without nuclei. They're very active cells. So this is exposed collagen. As soon as there is a vessel injury and exposed collagen, platelets have glycoproteins on their surface. So glycoprotein 1b9 helps them to stick to the collagen, that's called adhesion, and glycoprotein 2b3a helps them to stick to each other. And also note this fibrinogen. So fibrinogen is a plasma protein that helps platelets to stick to each other. Why we need to know this? Because in DIC, fibrinogen is low. So even if the platelet count is 40,000, 50,000, fibrinogen is low, so they have a tendency to bleed a lot more than what you would give for that platelet count. So they're all interlinked to each other. So this is where you have to spend few minutes, understand this, so that you're able to interpret your PT-PTT assay. I know you're all going for exams, but facing each patient is like doing an exam every day. You have to do what is right for them, and you have to ask for the correct tests so that you'll be able to guide them correctly with the treatment. So all we need to know is there are 13 clotting proteins in our body. All of it is made in the liver. Liver is the factory that makes clotting proteins every day, and only factor 8 and von Willebrand is made on the endothelial cell lining in addition. So all the endothelial cells of our body also make factor 8 and von Willebrand. And once factor 10 is activated, a clot is definitely formed. So factor 10 is the head of the family. Once it's activated, definitely prothrombin will get cleaved to thrombin. Thrombin will cleave several fibrinogen molecules into fibrin, and several fibrin monomers will stick to each other to form a nice fibrin polymer, and that is stabilized by factor 13. In order to activate factor 10, we have two pathways, one which we traditionally called extrinsic, another one is intrinsic. And only reason why we need to know this is it simplifies our way of interpreting the coagulation profile results. So whenever there's tissue injury, there is release of factor 7, and factor 7 is able to activate factor 10. That we call extrinsic pathway. So that's very simple. It only involves one factor, factor 7. Then you have another pathway which is called the intrinsic pathway, which has 12, 11, 9 and 8 put together. So each of them cascade, stick to one another. So it's like pieces of a jigsaw puzzle, and they all activate each other and then go on to activate factor 10. So this is a very simplified version, and you can see alongside there is always factors that help tell your body you can stop clotting. So these are protein C, S and antithrombin, because you don't want clot formation to be propagated for a long time. So in a simplified manner, we assess the integrity of the extrinsic pathway or amount of factor 7 in our body by doing prothrombin time. We assess the integrity of the intrinsic pathway or factors 12, 11, 9 and 8 by doing APTT. Anything below this level, factor 10 and below, both PT and PTT will be prolonged. So if you know that, then you'll be able to interpret tests much better. So this is what we thought before, but science has advanced. We know now that this is not what is actually happening in the body. It's far more complicated. It's not plasma-based clotting, but now we call it a cell-based model, and this was proposed by Hoffman and Monroe, how clotting is activated. So it's also easy to remember. Only from 2000 we understood clotting better. So we have an initiation of a clot, an amplification and a propagation. So this is easy because initiation predominantly relates to factor 7. So this is the extrinsic pathway. And then amplification predominantly relates to the intrinsic pathway, 12, 11, 9 and 8. And then the propagation is the kinase complex, things below factor 10. So it's almost similar, but it's a cell-based model. So IAP is how I remember it, and this is what we say. There's a clot that is initiated, then amplified and propagated. And you can see that platelet membranes are very, very active component of the clotting protein. So you need both platelets and the clotting factors to interact with each other to form a clot. And once the clot is formed, it's stabilized by factor 13. So you don't need any of these clotting proteins to stabilize a clot, only factor 13. So history taking is most important. You can do a lot of tests, but you have to sit and talk to the family. Without history taking, you're not going to be able to make any diagnosis in coagulation disorders, because by the time you finish your history, you need to know what you're going to have in the form of your results. So is it really a bleeding disorder? So was there bleeding from the umbilical stump? Where they had vaccines, did they have hematomas? When they were crawling around, did they have excessive bruising? Is it spontaneous hemarthrosis or prolonged bleeding following a dental extraction or surgery? These are hallmark bleeding history. They bought a new bike, they're trying to ride their new bike, they have multiple purple bruises on their shins. That is not really a bleeding disorder. Or sometimes, you know, my husband's an ENT surgeon, and I tell this joke, in all bleeding disorders, there's active tonsils. And when it's active tonsillitis, they go and operate and it bleeds, bleeds, bleeds. So that is not really a bleeding disorder, because when there is inflammation and you've gone and operated, there is prolonged bleeding. So you have to really say, is it really a bleeding disorder? So always rule out other surgical causes in a bleeding child post-op. This is the most important part of the history. What type of bleeding is it? Skin and mucosal bleed or muscle and joint bleed? So we said that the first two steps are vasoconstriction and platelet plug formation, and that's called primary hemostasis. The second step is the fibrin clot formation. So that is secondary hemostasis. So if anyone has a primary hemostatic defect, they'll have skin and mucosal bleed. And if they have a secondary hemostatic defect, it will be a muscle and joint bleed. So you'll never see a hemophilia patient, for example, with petechiae. And you will not see a child with a platelet disorder come in with a joint bleed, which is spontaneous. So even from the history, you'll know I'm dealing with someone with a platelet type problem or a clotting factor type problem. So what is this? Petechiae, ecchymosis, blood blisters in the mouth. Primary or secondary? Primary. Primary or secondary? This is hyphema. Primary. Primary or secondary? Hemarthrosis, gluteal muscle bleed. Secondary. Okay. So there are some conditions where you have a double whammy. You have a mixture of both primary and secondary. Only two conditions where you're in a peculiar situation. One is von Willebrand, because von Willebrand antigen is an antigen that helps you carry factor VIII in one arm and helps platelets to stick to each other in the other arm. So if you have low von Willebrand antigen, factor VIII is low, plus platelets don't stick to each other. So they can come with a combination of muscle joint bleed or skin and mucosal bleed. So it depends on the type of von Willebrand they have. So if you see someone with a mixture of both, think of von Willebrand, or in DIC. You have low platelets, you have low fibrinogen. So sick children, they can have a combination of both skin and mucosal and muscle and joint bleed. So you know it is a bleeding disorder. You know it's primary hemostatic, secondary hemostatic. Next you have to figure out, were they born with it and only now they're presenting to you, or is it something they've acquired recently? So the commonest history all of us as pediatricians ask are you related, cousins before marriage? So consanguinity. So all autosomal recessive disorders are higher in number compared to other families if they are consanguineous. So all of our clotting factor deficiencies are autosomal recessive except one or two. So von Willebrand is autosomal dominant, and factor VIII and factor IX are X-linked recessive. All the others are all autosomal recessive. So this is what type of inheritance? So X-linked recessive. So this is Queen Victoria's family. She was cursed, so she was the carrier, and all the boy children died and the girls were carriers. Okay, so this is a hallmark history of X-linked recessive. So the boys will be affected, 50-50 chance, and the girls are carriers. So supposing this boy, Prince of Prussia, if he were to have a baby, will his child have hemophilia? No, because if it is a girl child, she will be an obligate carrier, and if it's a boy, he hasn't given his X chromosome to the boy, so it stops with the boys here. Okay, so this is typical pattern of X-linked recessive. What type of inheritance is this? There's a mixture of girls, boys, everyone being affected. Some of them have died, some of them are in pink. So this is autosomal dominant. So this is typical of von Willebrand. This is the most difficult disease to give any genetic counseling because it has variable penetrance. So there's a 50-50 chance of your progeny being affected, but are they going to be mild like you, or are they going to be the severe form? We can't predict because it has variable penetrance. So von Willebrand, you always have to be careful. If the mother says, I've had von Willebrand, I'm okay doc, don't do prenatal, don't go with it. Always advise it's better to go for prenatal because her child can be a more serious type. Whereas hemophilia runs true in families. If the maternal uncle had factor VIII of less than 1%, this boy will have a factor VIII of less than 1%. So it's easier to do genetic counseling if it's hemophilia compared to von Willebrand. So next, we have to always ask for drug history. You know that these drugs are classic as platelet inhibitors. But the classic scenario we see as pediatricians is during the dengue season. So the child will have very, very high fever. So people are worried of febrile convulsions, so they give a combination of Brufen and paracetamol to bring the temperature down. So you have platelet dysfunction and platelet count is showing a downward trend. There are ulcers in the stomach because of the viral infection, and they have one vomit, it's filled with blood, everyone panics. So it's all a combination. So you have to have what history they have. All the clotting factor proteins, we said, are made in the liver, and that is why liver is a very important organ for blood clotting. So each of these clotting proteins have different half-lives. So factor VII has the shortest half-life. So you all know if there is acute liver failure, we check for prothrombin time, because we said that prothrombin time tells you how much factor VII we have, and chronic liver disease, we check for albumin. So factor VII has short half-life 7 hours. Factor 13 has a very long half-life 13 days. 8 has about 8 hours. 9 has 12 hours. So you need to know this because How often are you going to replace factor? Depends on what is the half-life. So if I have a child with factor 13 deficiency, I have to replace only once in 2 weeks. I don't have to give daily factor 13 if they come with bleeding. Whereas if it's hemophilia who's come with an intracerebral bleed, I know I have to give 3 times a day factor 8 in order to maintain the factor at 100%. So it's important, and factor 7 is the best. Prothrombin time is the best test for acute liver failure, which is why we do it in paracetamol overdose. Renal failure always is linked to, uremia is linked to platelet dysfunction. So if your platelets don't work, so they may be normal. So you'll see good nephrologists will never poke the kidney without dialyzing the child first, bring the urea creatinine down, because if they do poke the kidney when they are uremic, then they are more likely to bleed. So renal failure makes platelets dysfunctional. Malabsorption, you know, factors 2, 7, 9 and 10 are vitamin K dependent, and so any malabsorption, you'll have deficiency of these factors, so they can present with bleeding. So you look for all of these. So any bleeding disorders, this is what we ask. Just like primary immune deficiency, we always do a HIV screen. So bleeding, we ask for all of this history. So you've asked your history, you know for sure, okay, this looks like liver disease, this looks like platelet dysfunction, this looks like hemophilia. Then you ask for basic tests. Your basic test is called a hemostatic screen, and it's only going to confirm what you already know. So you'll do a count, never ask for HbPCV, never ask for TCDC ESR, that is all gone out of fashion. Never ask for bleeding time, clotting time, gone out of fashion. Clotting time was used at a time when we didn't have automated equipment to do prothrombin time and APTT. So it's no longer valid, and if clotting time is prolonged, even my grandmother can say that this child has a bleeding problem. So you don't need clotting time to verify it. So you wouldn't do CT anymore. So you'll have basic CBC, PT, PTT, fibrinogen and bleeding time. Then you will be able to interpret. All of us need to know basically how to look at a peripheral smear. So in a peripheral smear, you know that RBCs are in millions, and platelets are in lakhs, white cells are in thousands. So you have to see in a normal peripheral smear, all these beautiful ladies, like going to school, they all have to look similar, they're all red cells. These are the platelets. So the machine counts them by their size. If you're big, you're a red cell. If you're small, you're a platelet. These are the white blood cells, which are much bigger than the red cells and the platelets. So this is normal. These are what we call giant platelets. You can see they are almost the size of the red blood cells. So the machine will count them all as red cells. So sometimes machine count comes platelets less than 10,000. But on the smear, each platelet is 10,000. So this will be 1, 2, 3, 30,000 platelet count. So this is important for you to know. In DIC, there are several fragmented red cells. The machine will count them as platelets. So platelet count is 75,000. The child is bleeding. So you need to know even in the middle of the night, if something is not fitting into the jigsaw puzzle, go and see the smear and it will give you a clue as to what is happening. These are very tiny. You can see in this whole smear, there's only 1 or 2. Platelet count is 20,000. But they're very, very tiny compared to normal platelets. So if you see platelets which have very small mean platelet volume, you think of a condition called Wiskott-Ulrich. Hallmark, they come with a triad of bleeding, infections and eczema. So you've already made a diagnosis when you've seen the child. This is the best way to do a bleeding time if you have no other access to assessing primary hemostasis. You can look at the smear, you can do a bleeding time, but it has to be done correctly. You have to not do it in children less than 2 years. Their skin is so thin, it's so sensitive, but you'll not be able to assess bleeding time correctly. You have to inflate the PP cuff to 40 millimeter mercury, take a place on the arm where you don't have capillaries or blood vessel, have a 2 millimeter long, 2 millimeter deep cut, have a blotting paper, see how long it takes for the bleeding to stop. And if it is prolonged, there is a primary hemostatic defect. This is another concept which is difficult to get from reading books. So whenever PT or PTT is prolonged, we do a test called a 50-50 mix. It's very simple, because if PT or PTT is prolonged, we want to know, is it something to do with the blood clotting proteins, or is there some inhibitor that is inhibiting our assay? So you add 50%, you take half the patient's plasma, half the patient normal donor's plasma, mix it and repeat the test. By mixing and repeating the test, we are giving 50% normal plasma, and that is enough to correct the bleeding problem. So if you repeat, first PTT was 80 seconds. After I do 50-50 mix, it has come down to 30 seconds. That means there is a clotting factor deficiency in the patient. By adding 50% normal plasma, I've corrected the PTT. By adding 50% normal plasma also, still APTT is 70 seconds. Then there is some inhibitor that is preventing the assay and preventing the prolonging the APTT. So it's not a clotting factor deficiency. This is important because when we deal with pediatrics, a lot of the ENT problems, so they come pre-op PTT is prolonged. So acute tonsillitis, viral infections, especially enteroviral infections, you make antibodies, and these antibodies inhibit our APTT assay. So they're not bleeders. You can't label them as bleeders. So they will come, 50-50 mix will not correct, and then after 6 weeks, you get them back and do the PTT, the antibodies are gone, the inhibitors are gone, APTT is normal. So unnecessarily, we don't need to treat these children with FFP, and we don't need to label them as bleeders. So nowadays, we have these fancy automated coagulation analyzers. They are very cool because they have, as soon as the blood clots, the laser light doesn't pass through them, and that is read as a graph. The laser light gets cut off as soon as the blood clumps. So based on how long it takes for the laser light to get cut off, when it passes through the plasma, you have a PT or APTT time. So at the moment, all you need to know is if factor 7 is deficient, you will have a prolonged prothrombin time, and it's coagulation is as easy as your right arm, left arm. You have something to compare. The lab value is 13 seconds, patient's value is 20 seconds. It's prolonged. So that's how we compare. So just factor 7 deficiency, PT will be prolonged. If APTT is prolonged, you have to look for 12, 11, 9 or 8 deficiency, but we always do it in reverse because the commonest is factor 8. So if PTT is prolonged, I will usually ask for factor 8 assay first because that's more common than 9 or 11. And both are prolonged means it's common pathway, 5 or 10. If fibrinogen is deficient, then I would call it fibrinogen deficiency. In factor 13 deficiency, a clot is already formed. So if you have a patient who's bleeding, come with a prolonged umbilical stump ooze, but PT and PTT are normal, you think of factor 13 deficiency because PT-PTT will be entirely normal in factor 13 deficiency. Everyone okay? Shall I proceed? So some other concept people have difficulty understanding is what is FDP, what is D-dimer. FDP stands for fibrin degradation product. D-dimer means, as it says, D, double, 2 units. So when fibrin polymers are cut in our body, physiologically when a clot is formed, body neatly cuts it into 2 fragments. That's called D-dimers. So a physiological clot will only end up as DD dimers to dissolve it. Whereas if there's a pathological clot, as in DIC, then it can come in all sorts of numbers. One unit will be 2, another will be 120, another will be 70. It's all chaotic. So this is FDP and this is D-dimers. Both we can do on card test, rapid card test, to see what is FDP, what is D-dimers. Whichever you do in a child with DIC to follow up if the DIC is controlled, do it serially. One value doesn't mean anything, except in pulmonary embolism, where if you suspect PE, you don't want to do imaging in a pregnant person, D-dimer is elevated, it's a good screening test to say that there's a clot inside the body. So you have a normal screen bleeding child, think of platelet dysfunction. think of von Willebrand, because it can be very subtle in von Willebrand. Factor 13 deficiency or a fibrinolytic defect. Okay. So just to conclude, we'll say if you see skin and mucosal bleed, you look at the platelet count. If platelet count is normal, then they have skin and mucosal bleed. Think of a platelet dysfunction. If platelet count is normal and bleeding time is also normal, then it's a vessel disorder. This is one particular group you should know about, Henoch-Schönlein purpura. It's a vasculitis. They come with horrendous bleeding. They can have GI bleed, they can have hematuria. There's nothing wrong with their blood, but the blood vessels are inflamed. So they be covered in purpura, but these are palpable purpura. They are different to the normal purpuric spots you would see in low platelets. You can feel them, and a biopsy will show you vasculitis. CBC, PT-PTT will be normal. If you have reduced platelet count, you check for a marrow. Is it immune if marrow is normal, or is it deficient production? So that's how you work up. And if you have large ecchymosis hematoma, check for PT-PTT. If isolated prolongation of PT, think of factor 7. Isolated prolongation of APTT, think of hemophilia. If both are prolonged, think of liver disease, which is first, and fibrinogen deficiency. Everything is normal, think of factor 13 deficiency. So that's how you approach. A newborn baby and a fetus should have a normal platelet count. That's how we are born. So any thrombocytopenia in a fetus or a newborn is abnormal. So we have 15 minutes, what we've learned, to interpret some real life situations. What do we do in real life? And I just want to tell you a little bit about ITP and hemophilia, because these are the two that you would come across as a pediatrician to deal with these patients, and what you should do and what's right. So out of all the cases I'm going to focus a little bit more on ITP and hemophilia. So this is a 2-year-old child, classic history, had a cold cough, then come with lot of skin and mucosal bleed. You know skin and mucosal bleed, it is low platelet. You check a CBC, platelets are 10,000. You have blood blisters in the mouth, you have giant platelets in the peripheral smear. Platelet count is only 10,000 because there's only one platelet here. So this is a bone marrow showing lots of megakaryocytes. But did I really need to do a marrow in this child? So there are recent guidelines, both from the American Association of Pediatrics and from the British Society, to say if it looks like hallmark ITP, you don't need to do a marrow. But you have to be very careful if we are dishing out steroids without doing a marrow. You have to look at the smear. There shouldn't be any abnormal indices. If you see in particular nucleated red blood cells, if the differential count looks less neutrophils, more lymphocytes, you're worried, then it's always better to document a marrow. If there is a gut feeling, a niggling feeling to say this could be something other than ITP, always do a marrow, because it doesn't take much. And for doing bone marrow, you don't need to give them platelets, because it's just subcutaneous, the posterior crest, you can do and put pressure. But mostly it's not required. So should I transfuse platelets? There's only few blood blisters in the mouth. No, whatever platelets you're going to give also, this is immune destruction of platelets, so they're going to get consumed. So not all ITPs require platelets, only if you're suspecting impending intracerebral bleed or a GI bleed should you give. So you have steroids, you have IVIG, you have IV anti-D. This anti-D is different to the other normal IM anti-D that you give for RH incompatibility. This is an IV preparation and steroids. And in steroids, you have methylprednisolone, prednisolone, dexamethasone. So what you would use, you have to tailor it to an individual child. This is the latest concept in ITP. Before we thought ITP was just immune destruction. But now we know there is a combination of immune destruction plus impaired production. So it's not just immune destruction, but there is also impaired production. That's why when we treat children with ITP, now our approach is different. We are not just reducing the destruction, but we're also promoting the production by thrombopoietin analogs. So this is the new concept. So which steroid? Everything depends on the individual child. If there is a plump teenager, she's worried about getting pimples, she doesn't want to put on any more weight. it will be very difficult to give her 1 milligram per kg of prednisolone. So you have to tailor it to individual child. And vaccinations during steroids you try to avoid. Most of the children resolve. Only 15% will go on to having a recurrence. And childhood ITP is very, very different to adults. If you see someone with platelets not improving at all, coming back to you repeatedly, if it's a small baby, think that they could have an immune deficiency, and the first presentation is autoimmunity. If it's a teenage girl, think that this could be the first presentation of SLE. In all age groups, look for viruses. HIV, hepatitis B, hepatitis C, because that could be a manifestation. So these are the things you would look, and childhood and adult ITP is very, very different. In children, sometimes we can wait and watch. In adults, they never wait and watch, because here it's just an immature immune system. It's not able to see self from foreign, and when a virus enters the body, antibodies are made and they are destroying the platelets, and most of the time it's transient, whereas in adults it's a proper immune dysregulation. Any spotter here? So this is vessel problem, Ehlers-Danlos. So there isn't any treatment for it. Easy bruising, just to be careful. The connective tissue that must hold the platelet, the blood vessels are lacking. So there's no collagen support. This also you would see in your elderly grandmother, grandfather, and their skin is papery thin, and once they dash themselves on the wall somewhere, there's a big bruise. So that's lack of supporting connective tissue. You'll also see it in the children with nephrotic syndrome who are on prolonged steroids. So the connective tissue gets thin, so they bruise far more on their skin. That's called puppy skin. So this is one of my actual students who had come with a very brief history of easy bruising, but there was a previous history that last week had a acute febrile illness. Initially when she came, she was okay, conscious, but within a few hours became completely disorientated. So first thing, looking at the labs, I was thinking this could be meningoencephalitis. She's come with acute encephalitis because there's fever, there is altered sensorium, and she started bleeding. But what is telling me that it's different and it's not meningoencephalitis? The renal functions are altered. And if I look at the coagulation profile, PT-PTT is normal. So PT-PTT normal. In DIC, the first hallmark would be that fibrinogen goes down, PT-PTT is prolonged. Early DIC, they're not going to have renal dysfunction. So this is a condition which mimics DIC, but if you see, there are fragmented red cells which look like Greek helmets, and there's hardly any platelets. So this is a condition called thrombotic thrombocytopenic purpura, TTP. You have to recognize this early. You have fever and all the small vessel circulations affected, kidney and CNS, and you have microangiopathic hemolytic anemia and thrombocytopenia. So you think of all the meningitis and things like that, but that's what she has. And this, we've come a long way in diagnosis and treatment of TTP. We know that von Willebrand is a big protein, and as these big proteins pass through small vessels, they can cause shear stress on the endothelium. So body doesn't like these big von Willebrand proteins to be floating around. So it has these little proteins which we call ADAM-TS13 or von Willebrand cleaving protease, which has to break down von Willebrand into small particles so that they don't damage the endothelium. When this cleaving protease is absent, these huge von Willebrand proteins will damage endothelium, so platelets stick there, red cells get sheared as they pass through, and then there is tissue ischemia. So this is also an autoimmune condition. You've made antibodies against these von Willebrand cleaving protease. So this is a child for whom we did exchange transfusion, plasma exchange, and several sittings, 16 sittings of plasma exchange, and then gave her rituximab, and she's okay. Any spotter? So TAR. So a newborn with low platelet count. This is different. So you wouldn't think, if you have hand anomalies, you would think this is either TAR or Fanconi. But the hallmark in Fanconi, they don't present with any cytopenias at birth. Fanconi have DNA repair defect. They are born with normal blood counts, but because they can't repair DNA, over a period of time, they develop cytopenias after the second birthday. TAR gets better by their first birthday. So if you want to refer for orthopedic correction, do it at their first birthday. So these are the things you will think of for inherited thrombocytopenia. And Fanconi, you have excess chromosome breakage. So if you have all these somatic features, always examine a child to see. It may just be that they are short, bit more hyperpigmented, just a couple of cafe au lait spots or a flat thumb. So then you look for mitomycin C stress test in the peripheral blood, normal chromosome breakage, excess chromosome breakage. So that is clinching your diagnosis. Well neonate with thrombocytopenia. So this history is very important. 2 babies died in the immediate neonatal period, but this baby is completely well, but is covered in petechiae. So this is typical of immune cytopenia. If you have a sick baby, they are septic, but this is a well baby with thrombocytopenia. So I'd ask if the mother had ITP, or this is a condition called NAITP. This is very, very similar to Rh incompatibility. We have platelets in our body which carry antigen. If the mother is negative for the platelet, but the baby is positive for the platelet antigen, they develop antibodies which feto-maternal exchange will happen, and just like Rh incompatibility, destroy platelets in the baby. Only difference is this can happen in the first pregnancy. Alloimmunization happens early, and they are alloimmunized even in the first pregnancy. So here, immunoglobulins, IVIG is the way forward. Baby is very hemorrhagic. The only person's platelets that would suit the baby would be the mother's, because she's negative for the antigen. So we give washed maternal platelets if the baby is bleeding too much in this situation. What's this baby got? Kasabach-Merritt syndrome. So these are giant hemangiomas which use up all the platelets, consume all the fibrinogen. So babies come to you in DIC. So this is a very difficult condition, but now that we have beta blockers, steroids, vincristine and therapeutic embolization, they do better. Classic story, preterm baby and on the ventilator, platelet is falling. What are you thinking? Sepsis. So sepsis is the first marker would be thrombocytopenia. So it's worth doing serial CBCs on these sick children, because it will help you pick up sepsis early, and you replace vitamin K, watch. 7-week-old baby who's come with a sudden intracerebral bleed, prolonged PT-PTT. What are you thinking? Hemorrhagic disease of newborn. So this we could prevent by giving vitamin K. So I don't need to tell you guys what are the types of HDN. What sort of history is this? Muscle or joint bleed? Type primary or secondary? It could be anything, but on my CBC, platelets were normal, and PT-PTT, PTT alone is prolonged. So it's correcting with a 50-50 mix. What are you thinking? 12, 11, 9 or 8. But I'll ask for 8 first. So this was a child who presented to us with hemophilia. I want to spend a couple of minutes on hemophilia. X-linked recessive disorder, 1 in 5,000 males if it is hemophilia A, which is factor 8 deficiency, and factor 9 is 1 in 30,000. So it's rare. But factor 12 is the only factor where you have prolonged PTT but no bleeding history. So if you have a child with a prolonged PTT but there's no bleeding history, think it doesn't cause bleeding, factor 12. So it's X-linked recessive. There's a lot of guilt in the mother that she gave it to the child. We try to divide them into 3 compartments, severe, moderate or mild. Why? Because I'm just sitting here and talking, I can bleed, I'm severe. But in mild to in moderate, only after trivial trauma they will bleed, and in mild only after actual injury or surgery. This is important because all our treatment focuses on making the severe children into moderate so that they won't bleed spontaneously. So factor replacement, factor 8, each unit will raise the level by 2%, whereas factor 9, each unit by 1%. So we calculate, is it a muscle bleed, is it a joint bleed, is it an intracerebral bleed, should I take them up for neurosurgery? Based on that, we have to plan how much factor to give. There are lots of advances in hemophilia, and on average, we give 25 units per kg for these children. Each bottle it's a plasma product, factor 8 and factor 9. So we have to dilute it in water, not shake it, but roll it gently between our thumb and then infuse it over 5 minutes. When you're putting cannulas into these children, you have to be careful because even a tourniquet can cause a heavy bruise. Doing blood tests could also result in a heavy bleeding. So be careful with these. And major bleeding episodes are what we want to treat adequately. Pain equals bleed. So in hemophilia patients, if you see warmth, that means they bleed. You can't see anything. So it's very sad. Our current products, so many are there. But what are the advances? Advances is prophylaxis. Before they bleed, you give them factor 8 and give them 2 times a week factor 8 so that they'll become from severe into moderate, and they'll only bleed if they have injury. So this is the clinical severity which we were seeing before, but acute bleed, chronic damaged joints, we don't want to see them anymore. So we have to make sure that the future is bright for them. We have recombinant factor, which is virally inactivated. We have long-acting factor, and there's a new drug called Hemlibra, which has changed hemophilia. So factor 9 and factor 8 have to attach to each other. So Hemlibra is just a synthetic molecule which sits on factor 9 and cheats it into thinking it's body's own factor 8. So you have a synthetic drug which you can give subcutaneously once in 2 weeks, and hemophilia patients are waiting eagerly for gene therapy to help cure them. So this is a baby with PT and PTT prolonged, which is factor 13 deficiency. I told you factor 12 deficiency, no bleeding history, so not to worry. And this alone I will do last case. PT and PTT are prolonged with puberty menorrhagia. Think of von Willebrand disease. And if the PT and PTT are prolonged, afibrinogenemia, and the last one is platelet function, which we do with ADP, ristocitin and collagen, so that if this is just for you to interpret, this is if platelets are lazy, then they will stay here. If platelets work, they will go right down for all these 3, and it helps you make a diagnosis of platelet dysfunction. So want to end by saying thrombocytopenia, think of sepsis, ask history carefully, think of inherited factor deficiencies, use blood products carefully, and avoid causing more damage in these children. And do all the very best in your exams, but even better, make a difference in every child's life that you see. Thanks.